So let's start with some different clinical scenarios, and we can stop wherever you want. If you have any question, I will ask for sure our colleagues here in the round table, but you can participate if you want, you have any idea or any suggestion. So let's... Doesn't work? Now. Okay, so now is a video. I would ask you to stop it. Te diré que lo pares un momentito. So this is a clinical case. Can you restart the video, please? So this is yes, so here it's a clinical case. You can see there's a pielic stone, lower pole stone, and a simple renal cyst. And here you're seeing the CT scan and with a big cyst on the pathway. And then we decide to go for mini endoscopic supine surgery. So we start with drawing our landmarks. You know that we do the 0-90 degrees technique. So it means that we rotate the CM from 0 to 90, as we already have explained that, because the depth of the calyx is that we are seeing on ultrasound. It's exactly the same, but on X-ray. And then we start the puncture, and when we start with the needle, we see that some saline is coming, so it looks like we are in. But we have a renal cyst here, so we don't know exactly if we are in or not, or we are inside the renal cyst. And then we start with the guide wire, and we inject some saline, trying to disimpact the stone that is in the inferior calyx, because sometimes the guide wire, it doesn't go forward because the stone, it doesn't allow the guide wire to go furthermore. Can you stop, please, the video? So I will ask you what you would do in that cases like that, Marcos, that you know that you are inside because saline is coming. The guide wire, you cannot see from inside. You are doing endoscopic combine. You cannot see the guide wire from inside. And you can see that the guide wire, it's just staying on the inferior calyx. And what do you do?
To use the advantage of the combined approach, we use a flexible ureteroscopy to assist the PNL.
Yeah, so this is what we try to do, and we start with the flexible. Keep going with the video. So we keep going with the little view through the inferior calyx, trying to destroy the stone. If we are able to remove the stone from this impacted stone in the inferior calyx, but we weren't able to do that due to impaction. The basket was unable to move the stone, and we perform a retrography and stop the video again, please. And the guide wire, it wasn't inside the collecting system. Alberto, next step.
In this case,
you are inside of the, so you have the guide wire advances or only in the calyx?
So the guide wire is, we are not seeing that guide wire is inside the pelvis. We suppose that guide wire is in the inferior calyx, because we are seeing some saline, and even more right now, we inject some methylene blue to confirm that we are in the collecting system and we are not in the cyst, but we cannot see from inside the guide wire.
In this case, I try to play with the guide wire in order to advance it to the upper calyx, so, and if it's possible to go down the ureter. If it's not possible, and I'm sure that I'm inside, I try to make the dilatation and introduce the nephroscope to break the stone with a lot of take care to don't lose the guide wire.
Danny, what do you think? You agree with Alberto?
So I think that prior to dilating any tract, you need to make sure that the guide wire is in the collecting system. If you don't see the guide wire correctly placed, even a small length of it, you shouldn't dilate. So sometimes you need to start with the flexia, make room, and check that the guide wire is inside. And sometimes, if you find a little bit of guide wire inside, you can dilate using the Matryoshka approach, starting from mini to standard, if standard is the way to go, in order to minimize the trauma. But I wouldn't recommend to dilate if you don't see the guide wire correctly placed.
Giorgio.
Well, Davide knows very well that I don't like blue, but this is the only case with the renal cyst in which blue is useful, because you cannot have any blue in the cyst, but you have blue that you have placed from a retrograde approach. So you are in, definitely. So I'm sorry, but I will try to dilatate.
Goumas.
So from the beginning, I would use the ultrasound, because in this situation, for example, it would make it simple to make a puncture without seeing the renal cyst. But we did it this way. If I know that urine comes out, methylene blue comes out, then I will dilate. Of course, you have to be expert. You have to be, this is a situation with Stackhorn stones where it's not easily to dilate. So it is a risk that you can lose the tract, but I think you have to dilate.
Davide, any idea, different idea?
Firstly, I would have performed the puncture, as Dr. Goumas said, with the ultrasound, but aspirating the cyst, because the cyst is in the middle of our tract. So I would have aspirated the cyst, then I would have placed hopefully two guide wires. Both in the calyx, because they are stuck in the calyx, but I would have performed the dilatation as well upon one of the two guide wires. So having a second safety guide wire in case of something went wrong.
So any comment from the auditorium? Anyone wants to say something about this in this situation? No fear. The patient is alive, so no problem. Yeah?
So the guide wire might be underneath the mucosa. So can be that so the blue is coming because the needle went through the mucosa. So maybe it's not safe to dilate at that point.
So good answer. I like this answer. Let's see. Keep going with the video, please. So we are seeing the methylene blue coming. So for sure the needle is inside the collecting system. And the guide wire, we cannot see from the retrograde the guide wire coming. But since we know that we are in, finally we decide to go with the dilation. So it's a dogma that we try to repeat, that when we don't know exactly where we are, we don't like to do the dilation. But in cases like this, when you don't have any other option, because you have to do the puncture in that calyx, because there's a stone here there, so you need the space. Finally, we decide to go for dilation and to check where it's going the guide wire. And it happens exactly what he has telling you, that the guide wire was underneath the axis. So it means that the guide wire is inside the collecting system, but perforating a little bit the calyx. That's why we cannot see it. And then when you advance the ampla sheet towards the calyx, you have to keep it at the edge of the parenchyma just to see perfectly where is going the guide wire, that it's perforating the collecting system, and then you keep going with the lithotripsy. So this is what we have done. We place, as I told you before, always a safety guide wire, and then we start with the nephroscope, and then you will see on the right side, you have the nephroscope view, and you will see the stones are coming, so of course we are inside, and you will see that the guide wire is underneath here the calyx, because it has perforated. Sometimes it happens that even you are inside, the guide wire is perforating. It's not the preferred situation to do the dilation in this situation, but if you know for sure that you are in, you can go on, because even more if you know that you should do the puncture in that situation. Please stop the video, Marcos.
I think in a situation like this, it's a good indication to reduce the tract as much as possible regarding size.
I agree.
Of course, it is very difficult to have all the armamentarium, but it's a good indication for micro, it's a good indication for ultra mini, for mini micro. You only dilate the nephrostomy 2 Fates French, and if you are out, nothing happens.
Yeah, I absolutely agree. So in this case, we went directly with 18, but it looks a great idea to start with, for example, a 14 French per amplat sheet to see where we are, or even at 11 frames. We do that sometimes, and it's a good idea in situations like that.
It's important because so you have done something very, very nice and very elegant, and this is the way to go, but in your hands, because you are an expert. But there are probably many people here in the auditorium that they don't have the same amount of cases behind. And the message is should be clear. A guide wire should pass smoothly, and dilation should never be performed unless you are really, really an expert and know what to do. And what you did is brilliant. Stay a little bit away. So don't go too far in depth in order to make sure urine comes out. Otherwise, you will tear all the parenchyma, all the infundibuli. So it's great, but because we are an expert.
Yeah, so there's a small tip regarding what Marcos is saying is that if you don't have a small nephroscope like MIP system 12 frames, you can use your semi-rigid ureteroscope to do that. Because for sure, all of you have a semi-rigid ureteroscope. So then you can do an amplat dilator to 12 or 14 frames and just check with your ureteroscope that you are in. Of course, it's a long scope and you will be far away from the perc, but it's just to see that you are in a correct way, and then you redo your dilation. Okay, so keep going, please, with the video. So at the end, we start the lithotripsy, and we keep going with mini endoscopic combined interrenal surgery. So we do all the lithotripsy with any problem. At the end, we always place a flexible cystoscope and from the PERC access track, and then we check everything with both scopes. And we have finished the surgery, and then we like to see what we are doing. Stop the video, please. We like to see what we are doing when we retrieve the PERC access sheet, because we are not leaving any more nephrostomies. I don't know if you can see here, because the image is dynamic, but here you can see there's a jet. We will restart the video to see better, but you can see a jet. It's an arterial bleeding arterial jet coming from the tract. Can you restart the video, please? Play the video. Let's see here. You can see the jet. Here. Yeah. Stop the video, please. Here you can see it better. What do you decide to do? Nothing? Davide, something?
Because this slide asks for nephrostomy tube, but I mean, obviously I would put a nephrostomy tube. The question is, how should I do something to stop the bleeding operatively, or I hope that the bleeding stops alone by putting a double J and a nephrostomy tube? I mean, that's the question.
That's the question I'm doing to you.
The question is good.
Goumas.
So I would try to coagulate because it's a bleeder. The nephrostomy tube it doesn't have any coagulation properties. It just you can just follow the patient. But if you see something bleeding, you can coagulate it with a laser, for example.
Giorgio.
Yeah, I saw you were using an high-power whole-mule laser from Quanta. You put it into the coagulative mode, and you just coagulate the vessel with your nephroscope.
Danny.
So the vessel is asking you for coagulation, so I'll try to use it, but sometimes it does not work. So it's not that easy. It looks easy, but I don't know if it's the structure of the parenchyma. It's not akin to that of the prostate, in which we know how to coagulate the vessels. Here it works a little bit less well, but I give it a try for sure.
Alberto.
I usually don't look the tract, because usually I remove the nephroscopy first, and afterwards I remove the sieve. So I have no problem with the bleeding in the tract. I think that the collapse when you remove the sieve is enough to stop this bleeding. But of course, if I see it, I try to coagulate it. But I think that is not necessary.
Okay.
I don't think it's an important vessel. When you have an important vessel, you don't see anything. The thing is the magnification. Well, you see the vessel, and if you can coagulate. But I don't think that vessel is going to give any problem to the surgery. in my opinion.
So I asked to the auditorium, who's looking at the track when you finish PCNL? Okay, and who's not looking at the track? So more or less, is better to look at the track, right? And any other idea coming from the auditorium? Yeah, again.
I also agree that sometimes it can be difficult to coagulate with laser. So sometimes I just leave the ampoules sheet, or you can place like a Malecot catheter just to tamponate the bleeding.
Yeah, but in this case, it's arterial bleeding. Okay, I agree with Marcos that it's a little bit a magnification of the visions because it's a small vessel, but you can see that the jet is powerful enough to have a good bleeding. So keep going with the video. So we decide to go for laser. And as already has mentioned many of the colleagues, it's easy to do that maneuver with the laser beam and just adapting the laser settings like if you were in a prostate. I mean, it's just an arterial bleeding, and then we use long pulse, just 0.5 joules, 20 hertz, and then just firing close to the jet, you can stop that kind of bleeding if you see it. It's not always possible, but if you see it, I think it's a maneuver that you can do because it avoids a complication during the surgery. You see that at the end with the laser, we reach that, and we can stop the bleeding, and then you will see that the track it's not bleeding anymore, and we can see all the track without any problem. So keep in mind that even if it's a small bleeding, you can do that with the laser inside the collecting system. Okay, let's move to another clinical case. This clinical case is interesting because it's somehow related to your case, Danny. So look at the left kidney. We can see that we have stones on the inferior calyx, and we have clearly a diverticulum in the superior calyx. And as far as we can see on the pyelography, there's no connection in between the collecting system and the diverticulum. So, your approach, Alberto. First approach.
I need to see.
Sorry, I'm going to show you the CT scan.
CT, I need to
Yeah, so
see
it's just, I show you just the CT scan to show you that it's really a stone, a kidney stone, and the stone it's like above the spleen, right?
Is symptomatic, the patient?
The patient has infections and fever.
In this case, for this diverticulum, I have to see with contrast the morphology. If I don't know if I communication, I think that is not. There is no communication in the pyelography.
At least in the pyelography.
In the pyelography. In this case, I suppose that perform a ureteroscopic diagnosis and inject contrast inside, and if I can't see the communications on the infundibulum, in this case I think that the best option for the patient is a laparoscopic, perhaps. But the main problem with laparoscopic is that the parenchyma is not so thin, so it's not easy to localize that. But I think that the percutaneous approach is not possible because it's very, very difficult to make a puncture. And I think that by retrograde ureteroscopy is not possible as well. It's not easy for that. So I think that maybe the best option is a laparoscopic extraction, but in spite of that, I think that is not a easy laparoscopic for this.
So
she has another stone in the in the
right.
lower
So
colon.
what we have done is exactly what you have said, that we start with flexible ureteroscopy just to check if it was possible to look for a connection in between the. Sorry, I advanced you something. So just to check a connection between the calyx and the rest of the kidney, but it wasn't. So no connection with the diverticulum. So we clean up the inferior calyx without stones, but 1 year later, Good. 1 year later. Now. So, you can comment, you can comment. You want to comment? You want to treat it? Yeah, no, it's a no, it's a good question, but it's not. I mean, the patient, we take out the stone in the inferior calyx and we leave the stone in the superior diverticulum because we thought that the treatment that it's supposed to do that, it's so aggressive, like Alberto suggests, that to do a partial nephrectomy on the superior calyx, or even more difficult to perform a mini track on the superior calyx. So our idea was just let's see what it happens without the stone in the inferior calyx, and this is what it happens. So it's a struvite stone, it's effective stone, and right now we have a staghorn.
It's an effective stone. It's in the lower calyx and has a white infundibulum. So I think that infective, good lower pole is perfect for shockwave lithotripsy. It's possible with postural measure after.
But you mean right now, before the first case? In the first case, you're right. In the first case, we were checking if it was a connection in between the diverticulum and the rest of the kidney. That's why we perform flexible ureteroscopy. Okay, Danny, what we are doing now?
So I would ask for a DMSA scan first to check.
It works. It works perfectly.
It works perfectly, or
perfectly.
It works? Okay, I trust you. So because the solution would be easier. So if the kidney is not running.
Agree.
Yeah. So well, it begs for a PERC, several tracts, several goes, a lot of information to the patient because we are going to see each other for a few weeks in the hospital, risk of infection at least in the first go, and there's no other way to remove all this stone burden but a PERC in different tracts and goes.
Any idea, different idea, Giorgio, Goumas, Davide?
Given the fact that it's perfectly functioning, and given the fact that maybe the pelvis is not completely inside the kidney, I will go for a lap or robotic approach to remove.
In case like that, pyelolithotomy?
Yeah. And to do, it's what we do combined. Sometimes we have this kind of case. We start in doing the pyelotomy and we do a combined, but starting from the abdomen with the ureteroscope. So it's a pneumatic rears. There's nothing that is done like that, but you open the pelvis and you try to go out with this. Given the fact that the maybe is from infection and can go out.
So what?
It's very difficult to clean up all this kidney with only one PCNL.
Yes. This is a key message. The first thing to understand is the feasibility, the balance of all the risks and the information to the patient. That means that you cannot finish the case in one step like that. So you have to do multiple access. You have to be aggressive, of course. Your target is the complete clearance because it's an infection stone. I would treat the staghorn, maybe 2 procedures. And maybe in the second procedure, I will try to puncture anyway the diverticulum and leave a nephrostomy. What we saw in the past is that this kind of stone actually, it's made of many, many small stones. And they can evacuate only by leaving a nephrostomy. So it will take time.
How you reach the diverticulum through a PERC track? It is too high.
I think it is. The problem is the supine. It is the first time that in, I don't know, maybe 15 years, I turned the patient in a prone position in a case like that to puncture in the prone position because it's very high and very too medial. So it's a good indication for prone.
So that's what I did. I switched to supine from supine to prone, so it's my only prone case in more than 10 years, but I provoke a pneumothorax.
So the thing is, so sorry for interrupting, because we discussed this previously also with Cesare that was telling us he doesn't go over the 12. You can go over the 12 because the pleura, it's not in the, let's say, half external part of the subcostal space. But if you have to puncture this, the verticulum, you're going inside the pleura.
For sure.
For sure.
For sure. So I did that. I was inside the diverticulum, and I noticed that I had punctured the pleura, so I stopped the surgery. And later on, I have done a supine PCNL in two surgeries, but in the second surgery, with the second track on the middle calyx, I moved the kidney down, and then I was able to do the puncture direct to the diverticulum. So the idea here, I just want to comment that sometimes your PERC access sheet, it gives you the ability to move the kidney down, and then you can do the puncture towards the diverticulum, and I clean it up, but I didn't take it all the stones. So he want to have another stone in the future for sure. Yes. Because during the surgery, the PERC track, it moves, and then I was unable to redo the track.
Yeah, well, congratulations. You need courage and, of course, technical abilities and expertise. But, you know, endourology is magical also for this because it's not a standard every time procedure. You have to invent things, you know.
Yeah. So
we have time for only one case more.
Yeah, Alberto.
I think a question only is that this is a perfect case to remember the importance of acidification in patients with infective stones, because it's really dramatic, the growing of this stone, only for no acidification the urine. So it's very important in infective stones to remember that acidification is mandatory.
So right now we are giving to that kind of patients L-methionine plus acetohydroxamic acid. Are you doing something different?
We usually use acetohydroxamic or L-methionine.
Or both?
Plus,
Plus.
depending.
Okay. Any other comment?